Hi, I'm Jerry Hesch, Dr. Hesch, physical therapist at Hesch Institute in Aurora, Colorado. And I had a question on Facebook. Today is September 2nd, 2017. And I had a question on Facebook regarding the concept of aligning the pelvis on the surgical table, which is done in one part of the country prior to a sacroiliac fusion. And I had made the comment on this Facebook group that although I align pelvises, restoring symmetry of mobility and position side to side, that I did not believe that alignment on the surgical table by a physical therapist is a necessary prerequisite to a successful fusion of the sacroiliac joint. And this is the exact wording of the question. Jerry, why do you align pelvises if not necessary for successful fusion? First off, very few of my clients, very few of them require a sacroiliac fusion. I align pelvises to improve function of the body. PreSurgical pelvic alignment is an inadequate concept because it does not evaluate alignment of the middle and lower pubic joint on the surgical table. It does not evaluate the pubic fibrocartilage. It does not evaluate the medial, let me back up and go to it. It does not evaluate the fibrocartilage of the pubic joint. It does not evaluate the middle of the pubic joint or the lower part of the pubic bones. Alignment on the surgical table does not evaluate the posterior positioning of the ischia, and it does not evaluate the medial-lateral relationship of the ischia either. And so it's only partial alignment. So why would we want partial alignment on the surgical table? And simply aligning a person's pelvis as to how it lays on a surgical table, to me, makes no sense. It just doesn't make sense. The sacroiliac is inside the pelvis. And aligning the outer part of the pelvis on the surgical table has nothing to do with the relationship of the sacrum and the ilium. And it seems that that is what is being implied, and it's simply false thinking. And there is adequate research to support that statement, published some time ago. 1999, I believe, was when some of that research came out. And there are several studies that validate that. So, furthermore, this partial alignment does not clear the pelvis of subtle dysfunctions that are too subtle to be evaluated via alignment. For example, one pattern named downslip ilium is one which cannot be evaluated via palpation, via looking at alignment of the pelvis, because it is simply too subtle. It's a very small amount of movement. So it has to be evaluated by palpating the sacrotuberous ligament and inducing passive forces vertically through the hemipelvis and inferior forces through the hemipelvis. That's how that is diagnosed. And again, alignment theory, alignment technique fails to diagnose ilium downslip. It requires movement testing, which is named spring recoil testing. Now, I do not just align pelvises very thoroughly. Much more important than alignment therapy and how a pelvis looks from one side of the body to the other side of the body is how it functions. And I also do 16 basic passive spring recoil tests through the pelvic structure, and I also do 12 advanced tests of passive spring recoil motion testing through the pelvic structure, and the information I gain with that I couple with alignment. But the alignment on the surgical table, as is practiced, does not do any of those spring testing. Again, the reason I align pelvises when they can be aligned is to improve function of the body, and I immediately teach the patient, the client, how to do that to themselves to make them independent of me, not dependent on me. And I'll stop filming here. I'll do a second film which addresses the second question that was posed in that Facebook group.